Hello everyone. I welcome you all to this next MCS webinar. 2 months ago we had a webinar about the beginning course, basic course, and now we are going into the mountains of MCS-land. I welcome you all. Well, my name is Erik de Waal. I'm a cardiac anesthetist working in the University Medical Center in Utrecht in the Netherlands. I want to hand over to my co-chair, Katrien Kozarek.
Hi, everybody. My name is Catherine Kozarek. I'm a cardiac anesthesiologist at the University of Wisconsin. We're happy to welcome you to this second in the series Mechanical Circulatory Support webinar.
Okay, then I want to explain that, well, during this webinar, you can talk and ask questions. You can put them in the chat, and one or two questions will be taken after each session, and the others at the end. And possibly, if not all the questions are responded, then probably you will get an answer later. Then I want to introduce the first speaker, which is Yevgeny Potapov. He's a consultant cardiac surgeon and co-chairing and chairing of the MCS program in the Department of Thoracic and Cardiovascular Surgery at the German Heart Center in Berlin. He completed his medical training at the Free University in Berlin in 1996 and his PhD in cardiac surgery at the Humboldt University in Berlin. He has written over 300 papers in many different journals, and most about MCS, TMCS, and end-stage heart failure. And it's a great pleasure to have him on this webinar talking about short-term mechanical circulatory support.
Eric, thank you very much for the invitation. I think to the community to invite me to this topic. Can you see my slides? Okay. So my topic is bridge to heart transplantation with temporary mechanical circulatory support. So before we speak about the bridging, we have to see the indication for temporary mechanical circulatory support. And this is mainly is a cardiogenic shock. It is a rescue indication. You have to act immediately, right now. There are some other indications like preconditioning and candidates for durable MCS. It's an urgent indication. We can do it in 2, 3, 4 hours. Protected cardiac surgery. It is completely scheduled for the next week. And it is a bridge to decision, heart transplantation, or recovery. So today we will speak about temporary MCS as a bridge to heart transplantation. So before we speak about theory, I will show you some case. 53 years old patient, and she's decompensated, and she was on the high urgency list and decompensated. So she received ECMELA 2.1. It means she has Impella 5.5, and she has ECMO as a single arterial access through the axillary artery and venous drainage through the jugular vein. So the implantation was performed in the local anesthesia. It's a very important, we will speak later about, because these devices, ECMELA, providing full support up to 10 liters flow, may be, or at least in our institution, are implanted in local anesthesia if the patient is awake. So after some days on this ECMELA, we decide to de-escalate her from ECMO to the RVD, and she received RVD with Protect Duo. And you see here, she's now on temporal biventricular support with Protect Duo cannula and Impella 5.5 implanted again in local anesthesia. So, and in this configuration, she could be very good mobilized because all the cannula are on the upper body. Again, Protect Duo jugular vein and Impella through the right axillary artery. You see, she is lucky moving around, supported with a bunch of people. And she was transplanted 17 days later. Now about the development of temporary mechanical circulatory support. And look the data from Spain, not UNOS, not Eurotransplant country. with, I would say not enough, but large donor pool. And what we see now, percutaneous VD, this is the red box increasing over the years, and since 2018 it's increasing. And ECMO, still the same number, and completely less and less IBP, so almost no IBP there. This development in Spain, non-UNOS, non-Eurotransplant country. And from the same paper, you see the survival. And patients supported with ECMO till heart transplantation has the worst survival, the bottom line. And the best survival is the red one, percutaneous VAD, Impella. So patients supported with Impella has a better survival compared to ECMO. Now, there is a question about how to support the patients. Impella is better as a bridge to transplant than ECMO. And this fact and this development lead to increased number of Impella implantation in Europe, not only as a bridge to transplantation, of course, the adoption of the Impella technology in post-cardiotomy cardiogenic shock, in acute and chronic cardiogenic shock, but anyway, many of these Impellas are bridge to transplantation. What's about US? And we know, everybody knows that 2018 in UNOS area, the donor policy or allocation policy has been changed. And you see here huge impact on a strategy. 7.4 temporary MCS up to 22. So 3 times increase in temporary MCS as a bridge to transplantation. And less durable MCS. And I will show you some other pictures that's really impressive. And yeah, but main point is 3-fold increase in temporary MCS as a bridge to transplantation in the UNOS area. And if you see here in the numbers, neglectable numbers of Impella, and here over 500 Impellas in UNOS area, the same paper. So it is a change in the utilization of temporary MCS in UNOS area. What's about mortality? And the same paper shows you that mortality improved in the current area, but still the mortality here on the left side from ECMO is higher than in patients supported with IBP or with Impella. So again, in the current area and UNOS area, the mortality on the waiting list and mortality post-transplant mortality, 90 days mortality in these pictures improved with all the type of devices, but still the mortality on ECMO is higher than mortality on IBP or Impella. And this is a promised picture. You see here dramatic change in strategy of durable devices. 2017, 2016, and the highest number was 2014, 30% of patients are supported with durable devices as a bridge to transplantation. Nowadays, 22, after change in the allocation policy, 4.2. So it is almost not a seven time decrease in the implantation of durable devices as a bridge to transplantation. The majority now are destination treatment for 46, 49 to 82%. So again, the conclusion, since the change in the policy, we have higher 90-day survival on waiting list using temporary MCS, and we have similar post-heart transplantation 1-year survival. So, and this lead to the increased number of utilization of Impella, 5.5 in US, and you see here really double of number in, I would say, in 2 years, 22 to 24. So, but all these devices, the temporary devices, they are not sufficient in all patients. It's not that one fits all. So if you look on this paper published recently, Mandip Mir is a co-author, Akinobu Ito from New York. So you see here that survival on durable devices after heart transplantation is better on durable devices than in patients supported with Impella 5.5. Why? And the answer is very clear, that this picture shows you survival in patients type O on the left side and in patient non-type O. So the patient support with blood type O, they have worsened survival on temporary devices. And patients with non-type O, so A, B, or AB, they have similar survival if they are supported with temporary devices. So it's a clear message that the patients with blood type O, they probably should be supported with durable devices. And if we check through all this, then you have patients type O, normal height, left down corner, normal height and non-obese. The temporary device is better than, but it's not significant, but you see the trend. But if the patient has blood type O and is obese and not normal height, then the survival on temporary devices on the waiting list is significantly lower than a survival after durable device implantation. So it is very important to see that not all, even in US with, I would say, very good donor situation and very good donor supply due to opioid epidemic, even there, patients with type O, when expected long-term waiting time, the durable devices are better than temporary devices. So, in conclusion, for UNOS area, we have to differ. Conclusion for UNOS area, bridge to heart transplantation with temporary MCS is the best option for non-type O blood type candidates. And candidates with blood type O, we expect short waiting time, temporary devices may be used. In patients with type O blood and with expected long waiting time, some HLA antibodies or Bs, whatever, durable devices are best option for these patients as a bridge for transplantation. What's about our situation? You see the use of Impella 5.5 in Germany, so a continuous increased number, but it is not because of bridge to transplantation. The donor situation in organ transplant area is very, very tense. So we have not enough donor, and we do not transplant patients from Impella in Germany, or very, very few, and in oral transplant area. But this is the really high use or increased use of Impella, at least in our institution. And we prognosed for this year approximately 250 to 300 Impella used, but not because of heart transplantation. Again, I will show you this number. So, and since 5 years, the number of temporary devices, the number of Impella implanted surgically overgrow the number of durable devices, as you can see on the right side of this picture. And now the number of transplanted patients from Impella. I have not complete data, but I can tell you that in the last 2-3 years, only 2 dozen patients are transplanted from Impella in Germany. And this is around 1,000 transplantations. So it's maybe 2%. And you can see it here in this graph. You see 1 or 2 transplant from Impella each year. And this year, 2025, we have 1 patient on a high urgency list on Impella because of hypertrophic cardiomyopathy and VT. So he's a very bad candidate, would be very bad candidate for durable device. He is on Impella, awake, and he's waiting for heart transplantation. That will be probably 1 or 2 patients transplanted in Berlin from Impella. And Impella has a lot of advantages, and you can see this implantation in local anesthesia. And again, as I promised you, we implant in Berlin, we implant Impella. If possible, the patient is not intubated. We implant it in local anesthesia, and even ECMELA, the combination of Impella and ECMO, we implanted in local anesthesia. So I show you some quick how to do it. So I address only the subclavian artery area. So the transthoracic echocardiography could be performed, and our anesthesiologists, they are able to do it. And if you look on the face of our anesthesiologist and his posture, he is really lucky to do transthoracic echocardiography. He's the best in transesophageal, but probably the first time in his life he did transthoracic echocardiography. So, but just dressing the part, and then you can do it here. You can make a cut, implant Impella, and this is a transthoracic echocardiography. Parasternal view is completely enough to do it. So the conclusion for European countries with short waiting time, bridge to heart transplantation with temporary ACS is preferable in patients with expect short waiting time, and type O candidates with expected short waiting time. Temporary MCS, it's maybe acceptable. And conclusion for oral transplantation, if you speak about European countries with short waiting time, I speak about countries like Spain, Austria, where their donation policy is completely different to their, for example, in Germany, because by law, not everybody is a donor. He should be actively asked. So for organ transplantation, bridge to heart transplantation with temporary ACS is accepted only in children or in patients with biventricular failure or other contraindication for durable devices. And this is my last slide. Thank you very much for attention. Now, please, some questions.
Yevgeny, thank you very much for this interesting presentation. I don't know if there are some questions in the chat. I don't see any questions at this moment. But as you explained, if you have a patient with cardiogenic shock who is scheduled for heart transplantation, then you put, and the patient has a specific blood type, group A, group O, then you more easily implant an Impella. But what is then your policy in other blood groups? If you have a patient in cardiogenic shock, do you look first to the blood group in order to think about what are you going to do, or what is your policy in this?
Eric, I'm a surgeon. I do something first, and then I start to think why I did it. So, of course, if the patient is in shock, I have to implant Impella. And then we start in heart team with our cardiologist together to decide what to do. And if we think that the waiting time will be short, then we try to put him on the high urgency waiting list. And the last patient on Impella with hypertrophic obstructive cardiomyopathy, many surgeries, aortic valve, tricuspid valve, young patients, hypertrophic obstructive cardiomyopathy, bad candidate for LVAD, and we could not put him on the waiting list because of comorbidities. And then he decided not to he decided against LVAD. So in this case, it was the palliation. So we stopped the impeller, the patient died. So it is, again, implant impeller, and then start to think why and what is the direction. Is a bridge to transplant, bridge to decision, bridge to LVAD, bridge to palliation, or it's a bridge to maybe recovery. We have now a lot of influenza myocarditis, and the last month, 4 patients were supported with impeller with influenza myocarditis. All of them recovered, and we are very lucky about this, but this is a bridge to recovery too.
All right. Thank you so much for that excellent talk. We'll move on to our next speaker. Dr. Oksana Volod is a professor of pathology at Cedars-Sinai Medical Center and the David Geffen School of Medicine at UCLA. She's been the director of the Coagulation Consultative Service at Cedars-Sinai since 2007. She's an active member of the ISHLT and has sat on the Mechanical Circulatory Support Interdisciplinary Network Steering Committee since 2021. Her interests include clinical applications of viscoelastic testing and coagulation challenges and anticoagulation management in patients on MCS. Oksana, thank you so much for being here with us today.
Greetings to everybody. Can you see my slides in correct position? Thank you.
That looks great.
Thank you for great invitation and an opportunity to speak and for the introduction. I will focus today on the actual coagulation disorders that occur with the implantation of the devices. Those are my disclosures, non-related to the devices. As the clinical pathologist, I work very closely with the acute care team as well as MCS team, specifically with the pharmacist, with the anesthesiologist. So that's the reason, even so I may not see patients directly, on a daily basis, I manage patients with them through my computers. I have 3 screens in my office, so I get all information in 5 minutes. I will try to discuss both thrombotic and hemorrhagic events that can occur in those patients. And also as a clinical pathologist, I interpret results. So I would like to share some of the information, what would be the best way to interpret certain circumstances of the coagulopathies in those patients. And as you can see, there are several types of devices. And because as Dr. Potapo presented, I will discuss also the most common, which is ECMO and impeller. I would like to point the audience to the complexity of the coagulopathies that occur in those patients because it's truly multifactorial. Exposure to the non-biologic surfaces of ECMO or other artificial device creates right away a complex inflammatory response, which in turn creates coagulation activation, thrombin generation, and all this situation leads to this systemic inflammatory response. And that's the reason we used anticoagulation as a heparin initially to calm down coagulation cascade and keep patient in balance. But also what I would like to point that things happen almost immediately after implantation. And they are quite significant. Another point that I would like to say that in normal circumstances, our coagulation cascade is activated through the factor 7 tissue factor pathway. But when you have an ECMO device, which is contact surface or any other device, ventricular assistant device, the coagulation cascade is actually activated through factor 12. Factor 12 usually do not participate in coagulation. We heard about factor 12 because of COVID and inhibition of fibrinolysis. But when we measure PTT, yes, we activate acids through the factor 12. So the same happen in devices. So for this reason, I believe there is a novel anticoagulants, even so I do not discuss right now then, targeting those particular steps that leads to activation of coagulation cascade. And as you can see, there is both bleeding and thrombosis, and anticoagulants itself, yes, leads, if there is too much anticoagulation, it will potentiate bleeding. If there is not enough anticoagulation, that will lead to thrombosis, or if there is an antithrombin deficiency, that commonly occurs in ECMO patients, specifically pediatric patients, that leads to heparin non-responsiveness and also to thrombotic propensity. So this is a very difficult balance between bleeding and clotting that we have to keep in mind when we manage those patients. Actually, there was 2 articles that I put side to side, and those 2 articles, actually look at the patients with a VA versus VV ECMO. And as you can see, both one study is much more older study, the ECMO COVID, which is VV ECMO patient populations, much more recent study. But as you can see, even in those 2 different devices, the rate of the events, yes, is slightly different. Yes, we see much more higher rate of stroke in VA ECMO and then in VV ECMO. VV ECMO, we sometimes see more of the hemorrhage, yes, but not strokes, hemorrhagic strokes or other strokes. And we have also a rate of DVT and PE is coming slightly different, but is almost similar. But as you can see, both VA and VV ECMO do have all these significant complications that, again, they are multifactorial. What is the other interesting study that I came across, again, as a pathologist? I was looking at the autopsy versus clinical identification of those events in ECMO patients. And as you can see, prior slides were showing what it was detected. This slide shows that actually autopsy finding detects much more thrombosis and other findings in the patients on ECMO. There also risk on being on ECMO also increases those events. So sometimes patient we clinically cannot identify, but again, at the end of the journey on autopsy, we could see situations that lead to this thrombotic or bleeding events. Now, there was a small study, it's not a big study, but it was a small study that was comparing VA and VV ECMO. As you can see, they did actually extensive conventional assay workup, specialized assay, and they found also, yes, that VA patients has significantly lower platelet count, fibrinogen, and clot strengths, it indicates that they have more propensity to more consumptive coagulopathy. However, and of course, thrombin generation was high in those patients. What was also interesting, there was no difference in total bleeding or thrombotic events, but this group of VA patients received a lower median daily heparin dose. So maybe, again, anticoagulation targets cannot be same for VA and VV ECMO. We have to look at those devices as a 2 slight separate type of devices. Actually interesting that I went through many guidelines, and some of the major society guidelines, they do not distinguish VA, ECMO, or VV. They just say ECMO. Yes, the other interesting patient population and significant patient populations are pediatric patients. Unfortunately, I cannot present it a whole talk pediatric, but what I would like to point out that we always have to keep in mind the size is matter. So when we talk about patient blood volume in adult, 6 liters approximately, versus circuit volume, we have ratio 10:1. In neonates, we have much more lower blood volume to almost a similar circuit volume, and the ratio 1:2. So infant exposure to the circuit volume is much more higher, and that's and less of flow and more activation occurs. So again, this is the area that we have to understand better, and potentially more anticoagulation, but careful anticoagulation is needed for pediatric patients. So I would like, again, in a few minutes, I cannot cover, I have 10 talks for ICU team. Here I have 15 minutes, but I would like to point on the key things that I think we have to keep in mind. So in defect of primary hemostasis, we are talking mainly about platelet dysfunction and acquired von Willebrand syndrome. So what happened when there is an injury, von Willebrand factor unfolds, von Willebrand factor causes platelets adhesion to endothelium, and through the fibrinogen, there is a platelet aggregation occurs. When von Willebrand factor unfolds, yes, it degrades by the ADAMS13. ADAMS13 role we know in TTP, but ADAMS13 is usually degrades von Willebrand factor. So in the circuit of ECMO and Impella as well, the von Willebrand factor not only degrades, it becomes more susceptible to the degradation by ADAMS13. Actually, it's quite interesting because Dr. Potapov described that blood type O, they are less responsive to short-term devices. Yes, so in blood type O patients have the lowest von Willebrand factor level. So I don't know if there is any relationship. Now I will look into it, but blood type O, they have the lowest von Willebrand factor level naturally. I remember that at one of the events, there was a meeting and they were showing Impella, and I was looking at Impella, and it looks like high shear forces are generated through that device. And I keep asking representative, do you observe bleeding, increased bleeding? Do you have von Willebrand factor loss evidence in those patients? And they said, absolutely no. However, when we started to utilize Impella in our institution, my team keep reaching out to me that we have more and more bleeding than usual. So that prompted to this particular study, and we look at the, as you can see, this was just a small case series. So what is special about this? Patients are ECMO, Impella, or both, but majority of the patients are also in Impella. If you measure von Willebrand factor activity, it's not helpful because, as you can see, the values are very elevated and not always discordant. So I keep just sending for everybody multimers. Multimers take 7 days to get it back. However, in that place where we were sending to that laboratory, they were quantifying multimers. So they were not just saying multimers loss. They say how much multimers lost. And as you can see, in comparison to to WADs, yes, and durable devices and total artificial heart, ECMO and Impella patients have much more significant loss of multimers than others. So right now, I don't even recommend sending anything. I would accept it as it is. If patient is bleeding and you cannot explain it, that potentially also relates to the multimers loss of the von Willebrand factor. Another area that not too many people pay attention to, it's a factor 13. So what happened with the factor 13? Factor 13, when thrombin is formed, thrombin activates fibrinogen a conversion to fibrin monomer, and factor 13 stabilizes clot. So factor 13 makes clot stable. However, when there is a deficiency of a factor 13, PT and PTT and thrombin, none of the assay will detect it. So first of all, to identify this, you only need to measure actual level. The old test, urea solubility, will not detect level less than 5%, that it's not useful. So the other point that in hemostatic patient, level 5% is hemostatic, but in patients in ECMO, in our studies and other studies, they do need to have such a low level. Even with a level of less than 50, they will experience more significant bleeding. And as you can see from the study, they had a higher rate of transfusion. So again, something keep in mind when you see this increased propensity of usual ECMO to consider that there is a potentially factor 13 deficiency. Another area that may be not coming into like thoughts right away when we manage those patients would be DSC. Not too many case reports are out there, but few case reports are out there. However, I did also experience several DSC type of events in the patients on ECMO. And the reason for it, you have to kind of think about it. If you don't think about it, you may miss it. So because things that or laboratory findings that are seen in ECMO, they also can be seen in the patients of DSC. However, DSC, we are talking here about overt DSC. Overt DSC, it's mainly when it's not compensatory DSC. And usually by STH criteria, you have this consumptive coagulopathy is characterized by prolonged PT. So why PT is helpful? When patient is on heparin, even we know that heparin inhibits factor 210 and others. 210 is a common pathway. You would anticipate PT and PTT to be prolonged. However, PT reagent has a heparinase in it. So if patient is on heparin and there is no issues, PT should not be prolonged. If there is a PT prolongation, fibrinogen is going very down, D-dimers are sky high, you have to consider a DAC. What can help you in this situation? Factor 8. So factor 8 is not made in the liver hepatocytes. Factor 8 is made in endothelial cell. So if there is a liver issue or other issue, factor 8 is acute phase reactant is usually high or normal. However, if it's low, that it probably is consumptive coagulopathy, which will potentially require much more aggressive therapy and identification of the potential cause for this coagulopathy. As it was, I was introduced, my particular interest is viscoelastic testing. So I have a lot of viscoelastic testing here and my expertise is in it. So we run often TAG 5000 in this case for difficult cases because it's giving me a snapshot of what is happening. As you can see in this particular case, the patient has the red tracing represent normal ranges, and the patient tracing, as you can see, very different from normal. So there is a parameter prolongation, which indicates coagulation factors consumption, very low angle NMA, which reflects fibrinogen and platelets. So I did this, but again, I have to confirm my thought, and that's why I run other conventional tests. And as you can see in this particular case, factor 8 was 27. So this patient is definitely on type of consumptive ECMO type coagulopathy, had a DAC. So this is again something that to keep in mind. The other area that I would like to run quickly would be heparin and associated complications. This case, I'm usually presenting many cases because it's very visual and informative. So I was reached out that there is a patient on ECMO and ACT is subtherapeutic, and they increasing dose of heparin, and patient is bleeding and bleeding more. So again, I said, okay, let's do TAG, and within probably half an hour, I was able to tell them that there is a significant heparin effect. Actually, R value, which is, as you can see, just straight line, was running for 72 minutes, and I had to stop eventually. However, when heparin cap is added, heparin is removed. So the green tracing tells me that there is a significant heparin effect, and when heparin is removed, patient is not that hypocoagulable. However, and now with the history of ECMO, I was running additional assay to confirm my thoughts. As you can see, PTT in that patient was, because they only rely on ACT, yes. So PTT was more than 200 seconds, heparin level was supra-therapeutic. Patient has significant platelet inhibition and a loss of thrombocytopenia and a loss of high molecular weight multimer. So all of that combined multifactorial lead to, unfortunately, to intracranial bleeding, and support has to be withdrawn. So again, just telling you that how you cannot rely on one test. You need to kind of discuss with the team if clinical picture does not correlate with the laboratory findings. The other area that was heparin related, yes, we were looking because many times clinicians, okay, there is a thrombocytopenia, let's order a HIT workup, yes. And I wanted to remind you that patients who are exposed to the devices like ECMO or cardiopulmonary bypass, that the platelets are activated, and the screening assay will many times will be positive. However, the confirmatory assay, which is functional assay, not always will be positive. So I would like to kind of remind you, it's a clinical pathologic diagnosis. Order the test when truly you suspect a hit, yes, and not only you rely on the assay that is ELISA type of assay, yes, but you have to rely on a functional assay. We use serotonin release assay. Why this important? Because patient may be refused organ. When we had the case in this particular study, patient was refused organ because the PFO was positive, yes, and it took several days to receive SRA. and actually SRA was negative. It was not really hit, but organ was refused. What I was showing these slides because even not that statistically significant, there was this increased prevalence of hit in ECMO and Impella patient in our study. So again, keep in mind for those patients on the devices. And the last point on hit, I would like to say that it's also, we treat here, so patient potentially with a hit goes to the heart transplant, yes, so, or as a durable device, but needs a surgery that will require heparin exposure. We use plasma exchange in our institution. This is blood bank team area, but my area is the testing. So what is important to notice that functional assay in Dr. Workington and his guru and Dr. Greinicher is in Europe. Yes, they are hit people in the world. What they documented that functional assay will go much more faster down, which as like PF4 will still remain positive and for even longer. So this indicates that you can take much more faster patient to the procedure or surgery, which potentially requires heparin, but do not rely on the PF4 type of testing, to rely on the functional type of testing. And the last, when we are talking about antithrombin supplementation, with my colleague in Europe, Dr. Wachter, I was invited to write anticoagulation management in ECMO, which just, I think, just got published. But we were looking at about how different society approach antithrombin transfusion in patient and measurement. And as you can see, the only it's not recommended, there is no evidence or more evidence is needed, and only ISHLT recommends monitoring and loading if patient has less than 45%. So again, across the guidelines, because antithrombin requires for heparin. So if you just transfuse antithrombin and patient is on the same dose of high heparin, it can lead to patient bleeding. So that's probably there is this hesitance about transfusion of antithrombin, but this is something to keep in mind. I'm not sure I have too much time. I have several slides. I don't know, should I continue or should I stop at this point?
If this might be a good time to stop, if it's good time, if you have a couple more slides, I think you could finish. But
yeah, I have probably 5 or 6 slides. So maybe again, in terms of guidelines, the guidelines, I'm just gonna, yeah, one other slide, I probably, and this is where I stop. When we have discordant findings, when we run several assays in the laboratory for ECMO patients, and we have many times discordance, and most common discordance, PTT is supratherapeutic and anti-10A is subtherapeutic. 2 common reasons: if patient has a hemolysis and patient has a low antithrombin, the anti-10A assay will be not representative. If patient has lupus anticoagulant, which in our group of ECMO and other devices we found up to 70%, PTT will be affected. So when you have this discrepancy, try to consider those areas in those type of patients. So I will stop here because again, I will maybe continue and another talk, but my slides will be posted on the site. Thank you so much again, and I'll take if any question quickly.
Oksana, thank you so much for that very thorough talk. We have one question in the chat, and it's: is there any relation between ischemic strokes after temporary MCS implantation and increased coagulation after these implantations?
You know, there's not too much studies done on the subject, unfortunately, that I cannot comment, but you know, we were trying to do a study using Doppler, yes, and we didn't find any particular correlation in that group of patients.
Great, thank you so much. We have any additional questions that we see in the chat will be forwarded on to the speakers, and they will, after the talks are posted on the ISHLT YouTube channel, the speakers will be able to answer them there. So we'll move on to our last speaker, Dr. Amit Bardia is an associate professor of cardiothoracic anesthesiology and a cardiothoracic intensivist at Massachusetts General Hospital. He is the program director of the Adult Cardiothoracic Anesthesia Fellowship. He's an NIH-funded researcher with particular interests in perioperative outcomes aimed at improving healthcare delivery, education in echocardiography, and management of extracorporeal membrane oxygenation. Dr. Bardia, thank you so much for joining us today.
Thank you for the kind invitation. Thank you for having me. Just wanted to confirm that you were seeing the presentation and not two slides at the same time.
We see it just great.
Perfect. Thank you. So as I was introduced, I'll be talking about infections in patients with temporary MCS. These are my disclosures. None of this has any bearing on the talk today. So I have three objectives. The first objective is to discuss the epidemiology of infections in patients with temporary MCS. Second objective is to examine available perioperative strategies to reduce infection in this patient population. And the third objective is to talk about potential research areas to fill in the knowledge gaps that we have, and we have many. So case scenario, this is a typical case scenario. Most of the patients are in extremis, and it's almost a dumpster fire, unfortunately. We not only have to manage the patients, but also the healthcare teams around this patient. It's a multidisciplinary team that gets in and tries to resuscitate in eCPR, or at least manage the patients when patients are declining. So it's high tension scenarios for the most part, and we have to manage that. So let's talk about the phases of patient care when patients are receiving these temporary MCS devices. There's obviously the clinical presentation where the patient is usually in extremis, unfortunately. The patient undergoes device implantation. There's the post-device response. The patient further has in-hospital patient stay. And then our hope is their post-discharge health would be good and the long-term survival would be good. The goal is to reduce the collateral damage of healthcare association when we put these devices. As we know, the infections are multifactorial. There are host factors. These patients are usually sick with a number of comorbid conditions. Their immunity may be compromised. There's pathogen-related factors such as the virulence in the inoculum that they get. And there are a slew of perioperative conditions that may or may not be modifiable. Obviously, the device matters. Is the patient getting impeller versus is the patient has an open chest getting a central cannulation for a VA ECMO? Very different things, very different scenarios. What's the urgency? Is it an eCPR sort of a situation, or is it a more controlled situation where we have time and the patient can receive an MCS in a controlled fashion? What decontamination strategies was used? What was the sterility during the procedure? What antibiotics were used? So a slew of factors. Certain things make patients more susceptible to infection, such as elevated creatinine at the start of the procedure. What cannulation strategy was used? Higher SOFA scores at the time of cannulation, and pre-existing immune disorders or patients on immunosuppressive therapy. The epidemiology of infections in patients with these devices, pinpointing to a certain percentage is challenging because most papers are on single center reports. So obviously different centers have different strategies, different microbiome, so their infection rates are different. I've tried to present a few over the year. Most of these studies encompass more than one center, so maybe this is more generalizable. Usually we see that the bloodstream infections are more common with VA ECMOs and are pretty common. 33%, that's almost 1/3 of the patients getting a bloodstream infection. The VAP rates are kind of similar. The VAP rates on the VV ECMO that I show over here are patients who received VV ECMO for a non-pneumonia related cause, because a lot of patients already have pneumonia set in by the time they're getting a VV ECMO. the rates of infections are very high. The quoted rates are almost even like 75 infectious episodes per 1,000-day ECMO run. And these only go up as the duration of the ECMO goes up. So the longer the patient's on ECMO, the more chances that the patient will have an infection during their stay. Thankfully, the rates of infections are much lower in patients with Impella, so the collateral damage is much lesser. Obviously, it's a different patient population. Most of the infections are due to access-related infections. These are local wound complications. GPCs are very common in these local wounds, especially coag-negative staph. There's a paucity of data for infection for BIVADs and Centromag, but the infection rates fall in between the ECMO and the Impella range. The data behind infections on 5.5 is lacking. There are only a couple of studies that really talk about infection in 5.5. Probably this is because it's sort of a newer device. But one of the some of the literature that points to infections says that retained graft is a problem, and almost 10% of this patient population in the long term may have an infection because of that retained graft. So something to think about when these devices are explanted. Determining infection in this population, as we all know, in the ICU is challenging. These patients have, a lot of these patients have fever, white count. They have increased inflammatory markers. And we often have to rely upon secretions for diagnosing VABs. This is a typical chest X-ray of a VV ECMO. You know, we can't rely on X-ray related opacities because it often looks terrible. Unfortunately. And the other sign of sepsis, as we all know, is worsening hemodynamics. So if the pressure requirement is doubling or really rapidly rising, it potentially points out towards an infection. Similarly, for bloodstream infection, this worsening hemodynamics, need to put ice on the circuit. That tells me that the patient is mounting another response, and that's potentially sepsis. And as Dr. Waal said, the coagulation profile is altered in patients with these MCS, but an unexplained low platelet count may also point towards septic etiology. So how do we tackle these bloodstream infections, and what are the causative organisms? So the causative organisms kind of are based on what caused the infection. So usually if it's an ECMO catheter related infections, gram-positives are common, so is Candida, whereas if it's VAP related, gram-negatives are more common when the organisms seed from the lungs. UTIs are usually not a common source of bloodstream infection in these patients. And often when we are trying to find this out, it's always, we are trying to, as ICU physicians, we are often trying to figure out what caused this infection. Did the cannula cause the infection, or is it that some other source of infection was there that finally seeded the bloodstream? The literature varies a lot, whether to call it ECMO-related infection versus not. Some say call it an ECMO-related infection if it's 24 hours later after ECMO implantation. Some say 48 hours. So the literature varies. And the bloodstream infections are common, and they're very, very challenging to tackle because they often colonize the cannula and the membranes. And in some of the reports, it was mentioned that almost there's almost 30% mortality if the ECMO oxygenator membranes are colonized. So it's a very big problem. Another big problem is the common organisms that cause these bloodstream infections, such as Candida and Enterobacter, make biofilms on these catheters, make it very difficult for them to be eradicated. So how do we prevent these infections in the ICU? And the answer is, well, it's very difficult. Most of the guidelines pivot to good ICU practices to prevent these infections, such as reducing unnecessary breaking of lines, instituting a WAP prevention bundle. There's some early data showing that mupirocin decontamination may actually decrease infection in these patients, and aggressive removal of non-essential lines. Something that's highly debated is the use of prophylactic antibiotics when patients are on these devices, especially ECMO. And it's a very common practice when it was surveyed at various centers. However, ELSO guidelines do not recommend usual prophylaxis, routine prophylaxis while these devices are in place. There have been a couple of meta-analyses that show that although these patients who receive prophylactic antibiotics may have lower healthcare-associated infections, there was not a good mortality signal. And there's also, this is not a free lunch, there's also a signal that patients who've received carbapenems in the past tend to have more candidiasis. So Candida infection is a problem which is even more difficult to eradicate. So it's a very, very challenging problem. How do we treat these infections? As we know, antibiotics are primary modality that we use, and that also is fraught with problems, which I'll be discussing in the coming slides. We often get that useful note from some experts who say, oh, remove the cannulas when possible. Yes, we don't like to keep cannulas unnecessary, but often it's very difficult or not feasible to remove the cannulas in these patients because they may just not tolerate it. So this is the last part of the talk where I'll be talking about antibiotic therapy. Dosing of antibiotics is very, very challenging. There's increased volume of distribution, concomitant bleeding in these patients, and a significant proportion of these patients are on renal replacement therapy. There's some recent data that talk about the antibiotic levels in patients on ECMO. And these recent studies show that there's a marked variability in the PK profiles in these patients of over 30%. And this is only gets worse in patients on renal replacement therapy. As you can see in this figure, these are the commonly used anti-infectives that we use, vancomycin, piperacillin. The shaded gray areas show the actual level that we intend to keep to fight the bugs. This correlates with the MIC levels needed for their effect. And almost 50% of the times for these antibiotics, we don't even reach that level, that AUC level. So we think we are treating the bugs with the antibiotics, but often we don't even reach the MIC level to treat them. So it's very, very concerning, and we definitely need some more ways to tackle this problem. So finally, let's think outside the box. Let's look at areas where we can work to further research in this area. There's some initial data that shows that most of these infections are actually from the patient's own skin flora. So maybe genomic sequencing and finding resistance patterns may help us tailor those antibiotics that we use. Data on dosing and duration of antibiotics tailored to the pharmacokinetic profile may be helpful. And then strategies to tackle biofilms on these surfaces of these devices definitely would help in tackling infections. So just to conclude, infections are a major problem, especially after ECMO. They are common and multifactorial. Infections can tremendously impact long-term outcomes of these patients. And there's a lot of research that needs to be done. We have to think outside the box to control these infections because currently it's a major healthcare problem in these patients. Thank you.
Dr. Bardia, thank you so much for that excellent talk. We have a few more minutes for questions. If anybody would like to put any question in the chat. In the meantime, I just have a question about prevention of infections versus treatment. And you spoke a lot about the ICU kind of bundles that you have in place for prevention, which is ideally like the route you would go. But when you do develop these MCS-related infections, particularly when cannulas and oxygenators are colonized, how is your treatment different from somebody who's not currently on MCS?
That's a great question. Unfortunately, this will be a clinical answer based on clinical gestalt rather than literature, because there's not a lot of literature in this area. But usually, if a patient has a documented infection, obviously we do serial blood cultures every day once we start antibiotics, just to make sure that the antibiotics are actually treating the patients. If it's vancomycin, we take vancomycin levels to make sure we are reaching the MIC that it requires. Usually, we know we are getting a good response when the blood cultures are negative, when the patients are on antibiotics. We usually treat it for 2 weeks, as long as the echo shows no valvular involvement by those bugs. And in certain situations, such as candidiosis, sometimes the antifungals are continued till the device is there, because they are notorious for forming biofilms. And then we kind of, once the device is removed, then we kind of stop it a day or two later, as long as the cultures are negative.
Great, thank you. And then we have another question in the chat that kind of segues very nicely into that. Do you do secondary prophylaxis on a patient on ECMO who has a colonized circuit after a bloodstream infection with Candida?
We routinely, so it's basically, I kind of covered on it. We usually do not draw, at least at our center, do not draw cultures from the line itself. We usually do a fresh stick from the patient. And as long as the patient is not growing Candida in the bloodstream, we quote unquote consider them treated. But it's not uncommon for us to continue the antifungals till the device is still in there.
All right, great. Well, thank you so much for that very thorough discussion. Just a few points. This session has been recorded and will be posted to the ISHLT YouTube channel for viewing later. If anybody has any additional questions that we didn't get to throughout the talk, you can submit them. ISHLT members can submit them on ISHLT Connect, and non-members can submit them to the ISHLT YouTube channel, and we'll make sure the speakers receive your questions. The next ISHLT webinar is the Pathology Professional Community webinar on February 18th. And I'd like to turn it back over to Eric for any other closing comments.
Catherine, thank you very much. Thank you very much for you for all being here, for listening to these great talks about TMCS, a very interesting subject which we are with which we are confronted nearly every day in cardiac surgery. So thank you very much all for being here. Thank you, Catherine, for co-chairing this session. Thank you, Juliet, for your help for this great webinar. And well, for me, I want to say have a nice evening. Here in the Netherlands, it's dark, but probably in the United States, it's still daytime. So enjoy your day, enjoy your evening, and we'll see each other soon. Thank you very much.